as a clinical researcher, but I did not start, I didn't start until late in my career. So people may not know that. As a resident, I really had not done any substantive research up to that point. As a chief resident, I started engaging in research and thinking about that as I was thinking about that I would like to pursue an academic career. And so then I pursued a fellowship and got an MPH. And so really my research career started after residency and really during and after residency. So I just want to pass on to you all that to have a research career doesn't mean that you have to start in high school, right? You can choose at any part, and that as physicians, we are in a unique position with the knowledge that you have, the knowledge that you're gaining, to really impact clinical care for our patients in the future. And so I hope that you have a thought, about that and how you might pursue that. If you haven't spent time doing research and you're early, you're an intern or second year, we call them JARs, but second years, even in fellowship, I would encourage you to spend time with people who are doing stuff that's of interest to you. Maybe that's something in a lab, maybe that's something, with big data, now that we have EMRs everywhere, maybe that's something, conducting primary research, collecting data on surveys or on patients that are coming in, and give that a try. You don't need a PhD, you don't need these sort of things, but I think if find you're interested, then I would pursue additional research training. I'll say that research, I've been thinking back, one of my mentees, actually two of my mentees were just promoted to professor this year. I got to start working with them as residents, actually for both of them, and fellows, work with them through fellowship. It's been, as I think back about their careers and the projects we've worked on together, that's been really one of the most rewarding pieces of my career. I love my patients and do that. I like administration, obviously, or I wouldn't be in this job. But looking back at some of the projects we've worked on is really, I feel, made a contribution beyond what you can do on a one-to-one relationship with your patients or even in one institution. So it's a lot of fun. I think if you have curiosity in you, if you are wondering why do we do things this way, why didn't this patient do better, why can't we treat this particular disease, this is the opportunity to really be thinking about it. And again, as physicians, you have that inside knowledge, right? You're seeing this every day when you're seeing with your patients. So welcome again. I'm looking forward to the presentations and the posters for today, and I hope that you all bring your curiosity and have a lot of fun. Thank you.
All right, we'll get started with the oral presentations. Each person has 10 minutes for each presentation, and then there's a 5-minute period for questions and answers. I'd ask the speakers to please keep to the 10-minute time so that we get through all of the presentations and have time for questions and answers. The first presentation is Peng He, who's going to talk to us about loss of EphB2 kinase activity leads to abnormal crypts during regeneration after intestinal injury. His mentor is Michael Verzi.
Hi everyone, I would like to thank the organizers for choosing my abstract for our talk today and giving me this opportunity to tell you a little bit about my research on intestinal regeneration. I don't have anything to disclose, so I'm just going to start. First, I want to talk about injury, and specifically in the context of inflammatory bowel disease. Now, inflammatory bowel disease is systemic inflammatory disease, mainly infecting the gastrointestinal tract. It's actually an umbrella term for two distinct entities. The first one is ulcerative colitis. It is characterized by continuous inflammations from the distal colon to the proximal colon, affecting mainly the superficial mucosa and the submucosa. And the second entity is Crohn's disease, which is characterized by patchy inflammation that can happen anywhere in the gastrointestinal tract, and it's a full thickness inflammation that causes wall thickening, cobblestone appearance, fistulization, as well as stricturing. Now, this is a growing problem in the United States. On the right, these are CDC data showing the prevalence of both diseases are increasing. Currently, there's approximately 2-3 million Americans with IBD, and we're spending approximately $13 billion each year on treatment of IBD. So big healthcare burden for us. So the pathophysiology of IBD is quite complicated. So in the red circle is the classic activation of the immune system, cytokine release, and inflammation. And that's what our current therapies are targeting. Only about half of the patients actually respond to these therapies. Outside of this, we also have increased mucosal permeability, so barrier dysfunction. We have changes in the microbiome leading to dysbiosis and also oxidative stress. And there's really a knowledge gap in what's targetable in those components of this vicious cycle of pathological propagation of chronic inflammation. Today, I'm going to focus more on the mucosal regeneration aspect. So one of the ways we can actually model this ulcerative colitis in mice is we give them this chemical called dextran sodium sulfate. It's a polymer. It's very easy to use, so it's actually one of the most popular models. You add it to the drinking water, give it to them for 5 to 7 days. And on the right are the histology showing essentially inflammation starting around day 3 and day 6. You can get very significant distal colitis in the mice, leading to ulcerations around day 9. They actually lose weight, as you can see from the weight curves, and also they can develop rectal bleeding as well. So the classic symptoms of ulcerative colitis for patients. And then if you let them recover on normal water, they can regenerate the epithelium on day 12 and 15. And the regeneration process is actually quite complex. So these are 3D microscopy pictures looking at the epithelium as they regenerate after DSS colitis. So in A is the normal colon epithelial cells. We're looking down on it, and these little circles are looking down on the crypt structures. And at the bottom of each of the crypt structures sits stem cells. And in this mouse model, they are actually able to label each crypt individually with a fluorescent protein at random intervals. And then early on in the inflammation, day 7, you can see that these crypts start to undergo atrophy, and they fuse together to form this sheet of proliferating epithelial cells. Around day 11, they lateralize, they spread out to try to reestablish the important barrier that protects us. And then later on, around day 20, they undergo morphogenesis and fission, and they try to reform these crypt structures to reestablish homeostasis. Now, a big question in the field is, how do cells know where to go, right? This is so complicated. So to answer this question, I'm focusing on type of signaling called FB signaling. We know that during homeostasis, it's very important in establishing tissue boundaries. The FB receptors on the left, stained in red, are mainly expressed in the cells at the bottom of crypt. So these stem cells, these supporting cells that establish the stem cell niche. And the ligand is actually expressed in these differentiated cells on the top of the crypt in green. So here's a short video. I hope this works. But essentially, when a ligand receptor cells see each other, they touch and they repel. And that's how they establish boundaries and sharp lines. And actually, that's how all of our tissues establish boundaries and sharp lines. Now, again, knowing that this signaling is so important in establish boundaries, we think it also dictates how cells regenerate and know where they go during the regenerative process. So we hypothesize that if we remove this, we can potentially trigger abnormal inflammation and regeneration, and that could be part of the pathogenesis in IBD. And to see whether FB2 actually changes in the DSS colitis model, I used the existing single-cell RNA sequencing data that's available. So for people, majority of the audience who's not used to this, essentially we break the colon into individual cells and look at gene expressions. And these plots are called UMAPs. And they represent, essentially, each dot represents a single cell and their gene expression. And cells that are the same tend to cluster together. For example, in A, we're looking at APCAM, which is a marker for epithelial cells, and this cluster lights up, and that tells you that this is the epithelial cluster. Now, if we look at Ki67, which is commonly used proliferation marker, parts of the epithelial cell cluster lights up, and that tells you these cells are actively proliferating after DSS colitis. And if we look at FP2 signaling expression, you can see that that area overlaps with the Ki67 cells. I kind of broke this down into a time course, and you can also see that as we progress from day 9 to day 15 in this data set, we see increased FP2 expression in the epithelial cells as well. So this seems to supports our hypothesis. So I went on to develop a transgenic mouse model where I can inject them at any time with tamoxifen and delete the FB2 gene specifically in the epithelial cells to see what happens when they are exposed to DSS colitis after removing the FB2 gene. So I inject them with tamoxifen for 4 days, give them a 5-day kind of break, and then expose them to 2.5% DSS, and then collected the tissue around day 8. So here's the control tissue. Just want to go over what's normal. So in the FB2 knockout that are just given water, they actually have pretty normal colon. This is called a Swiss roll, where we roll the entire colon into a single section so we can look at the entire length of the colon, and you can see these nice parallel normal crypts throughout the entire colon. This is a control animal with intact FB2 exposed to DSS, and you can see there's a lot of distal colitis, infiltration of immune cells into the tissue. But the proximal colon, where you have those folds in mice, are pretty normal. Now, if we knock out FB2 in the mice and then expose them to DSS, you can see a very different picture. So not only do you see more proximal inflammation, you also see a lot of skip lesions, thickening of the colon wall, as well as these fissures with a lot of infiltrated lymphocytic infiltrates and abnormal proliferation of lymphoid tissues. When I look specifically at these lymphoid aggregates, they are enriched for CD4 positive Th cells. So this is very interesting. Now, I'm not going to go over this entire diagram in 30 seconds, but I put this in to essentially show that there's a lot of crosstalk between the epithelium and the immune cells. So we think that this is potentially triggering a different immune response. And hopefully, I'm trying to convince you that, by removing a single protein, the epithelial cells, we're going from a traditional ulcerative colitis model to more model with more Crohn's-like characteristics. The future directions would be to molecularly characterize this model, understand what's going on to the immune system using immunostaining and single-cell RNA sequencing. We're going to also try to validate this potentially in human samples, to give this more human relevance, because again, that's something we always need to keep in mind working with animal models. And of course, I couldn't do this. This is the most cluttered slide I have. So essentially, I would like to thank everybody for their support and help in this project.
Yeah, very interesting. So how do you think could this be therapeutically exploited?
Yeah, so the question was how this can be therapeutically exploited. So the interesting thing is I also have another mouse model where they don't have, they have essentially a non-functional FB2 in the whole body, right? And they actually don't have this phenotype change. So potentially that means that inhibitor, for example, might be helpful in helping utilize, switch this and control the type of inflammation that we're seeing potentially in Crohn's disease. Oh, there's a question in the back.
Are there any known inducers of or repressors of this gene from the environment, either like lifestyle, small molecules, gut bacteria, or anything else?
Yeah, so the question is, are there known inducers or inhibitors, natural inhibitors from microbiota or other influences, environmental influences? Yes, actually. So FP2 is very much downstream of TGF-beta, actually, as well as Wnt signaling. It's kind of a node for both type of important signaling to maintain the stemness and regeneration. And both of these are induced during inflammation, for example. So that's also why we're very interested in studying this.
Great, thank you so much. All right, thank you for keeping in time. The next presenter is Andrew Wang, and he's going to talk about analysis of primary care referral for patients with metabolic dysfunction-associated steatotic liver disease, identifying high-risk patients, and his mentor is Anish Patel.
Okay. Thank you for inviting me to speak on this, and I'm glad I'm not the only one that will inevitably stumble on this acronym, so here we go. I don't have any sort of disclosures, and essentially we'll be talking about, certainly the background of MASLD, the epidemiology, current screening recommendations provided by our kind of governing bodies, and then also really the crux of this will be evaluating our current institution's practices with referring to hepatology and gastroenterology, and also, kind of the data surrounding that. And of course, how do we take this from in the future, and how do we do, how can we potentially improve how we manage MASLD? So as many of you guys know, certainly MASLD has a lot of different sort of governing factors that can influence it. But really one of the, the main things that we look for, hypertriglyceridemia, diabetes, hypertension, these are all predisposing risk factors that can potentially lead a patient to develop MASLD. So a lot of different things, a lot of different factors that are very important. Now, of course, the really important distinguishing factor is that they aren't regular alcohol drinkers. They drink less than 20 grams of alcohol for females, and then 30 grams for men. So what we've kind of noticed over the last couple decades, 3 decades, is that prevalence has been steadily increasing and quite rapidly. A lot of studies estimate that prevalence in the 90s was closer to 25%, and now the projected prevalence by 2040 is going to be somewhere probably closer to 55%. That's pretty remarkable. And part of the problem with current practices and current evaluations of patients with MASLD is either they're too early or they're too late in the disease course to make a really meaningful change in their clinical outcomes. A lot of patients present to the hepatology clinic as decompensated cirrhosis. And of course, sometimes this also manifests with hepatocellular carcinoma. So certainly very late in the disease course. And a lot of the current practices revolve around using LFTs as the primary way of assessing for fibrosis rather than other dedicated measures like transient elastography, FIB4, ELF, and other sort of markers. And of course, LFTs can be markedly, pretty unreliable in terms of evaluating for fibrosis, because people with advanced fibrosis, they have normal LFTs. So this figure, of course, is adapted from our governing body for MASLD and causes a lot of different liver disorders. But really, the primary thing that we worry about, and the first thing we do, is to stratify them using the FIB4. And many studies have compared, what are the thresholds and what kind of limits do we set for progressing to the next step in evaluation. And typically, FIB4 above 1.3 is when we move on to the secondary evaluations in terms of transient elastography or VCTE, and also other sort of serum markers like ELF. And based on the secondary measures, then we progress to the next point where we refer them to specialists and pursue a higher level of care. So really what our project was looking to do is look at what are the referral practices within our institution, and between the primary care clinic and then the gastroenterology hepatology clinic. And additionally, kind of compare that using our non-invasive assessments like FIB4, kind of our initial markers, and then also comparing that against other sort of secondary assessments like vibration-controlled elastography or VCTE. So essentially, we obtained an IRB, we chart reviewed, obtained about a cohort about 160 patients, and then we compared using data. And here is our baseline characteristics for a lot of our cohort. Initially, with the 164 patients that we selected, it actually turns out that only about 2/3 of them were actually at risk for MASLD based on their medical comorbidities. That being like type 2 diabetes, uncontrolled hypertension, and certain levels of hyperlipidemia, hypertriglyceridemia. Interestingly enough, when we afterwards calculated their FIB4 scores, they're all pretty consistent, which kind of is an interesting thing that we'll talk about in a little bit. Now, just generally, some of the data that we obtained through this cohort, certainly over time, referrals increased. 2019 certainly was an interesting year, but over time, the prevalence seems to also increase, especially with the recognition of this as a unique entity. On the right side of the screen, interestingly enough, the reasons for referrals could have a very wide variety of different reasons. Some of them were just based on imaging findings, which we know are sometimes insensitive, abnormal LFTs, which I kind of already alluded to before, and also only 5% of them actually were based off of normal fibrosis assessments. And then when we looked at before referral and after referral, only 22 patients actually received any sort of formal assessment, including elastography. So certainly something that can be improved on. So when we took this cohort and we stratified them based on the FIB4 scores, so a FIB4 of 1.3 and below and 1.3 and above, we found some kind of interesting data. We compared these stratified patients against their fibrosis assessments on their elastography, so their estimated level of fibrosis. And we noticed that with the lower scores, below 1.3, about 84% had F0 to F1 disease, which essentially translates to either no disease or mild disease in terms of fibrosis. We kind of used F2 as our clinically relevant and clinically important fibrosis amount. And when we took it and compared it to the FIB4s above 1.3, we saw that the numbers shifted a little bit. There's certainly more clinically relevant disease, but still a large portion of them that had mild to clinically insignificant disease. And then when we kind of compared these, one thing that I really wanted to highlight is that the negative predictive value for a FIB4 of below 1.3 for clinically relevant disease was actually 85%, which is consistent with a lot of the data that's out there. So, the really important things, and what I really want to highlight with this study is that because MASLD has become one of the most common etiologies, it's really important that we get a good handle on managing this effectively in the primary care setting. A lot of our data shows that even the patients that come to our clinics from the hepatology side, 80% of them don't have advanced fibrosis, so they could still be managed regularly in the primary care setting. And additionally, it also kind of shows that we can do more empowerment in terms of primary care physicians being able to use those sort of non-invasive assessments to really kind of stratify those patients and identify high-risk patients down the road. Of course, the FIB4 isn't perfect, but it's relatively easy to use. It's accessible, and you only need 2 essentially blood tests to really assess for this. And ultimately, with the advent of GLP-1 receptor agonists and resmetirom, we have certainly more medications in our repertoire to really do an effective job of combating MASLD, preventing further fibrosis and progression of the disease. So a lot of different things that we can really work on. Certainly, our study has its limitations. We had a pretty small sample size, We only used ICD codes restricted to MASLD or NAFLD at that time, and this is all retrospective. Certainly we could have used a larger sample, and also we wanted a larger sample for the FIB4s that had assessment above 2.67, but we just didn't have enough patients to have a meaningful analysis of this. And of course, elastography by itself is imperfect. It doesn't, it's not the gold standard for assessing fibrosis. So certainly, it still has its limitations. But what I'm really most excited about is kind of the future directions of this project. Certainly, we can expand the reach, get more data, and we can also assess, how primary care physicians feel in terms of managing MASLD, but really what we can do, and really simple nuances that we can add to our EMR, our systems, is just utilizing FIB4 assessments regularly. Anyone who's at risk, anyone who has type 2 diabetes, poorly controlled hypertension, hyperlipidemia of any sort, to just utilize this, and most people have already existing CBC, CMP, so we have all that data there readily available. So to utilize just even the simple dot phrase, and for my co-residents, there is the FIB4 dot phrase that I just plug into most of my patient encounters now, which is very, very helpful. And if you see that number above 1.3, you think in the back of your mind, I think this is a good opportunity to get an elastography. Additionally, other ways we can kind of tackle this are through like care quality gaps, best practice advisories, to again enhance the amount of systems that we can to increase screening and recognition of MASLD as a disease entity within our populations and our institution. So a lot of different things that we can work on, and certainly education of both residents, primary care physicians, all these things will be very crucial. So thank you to Dr. Patel, Dr. Lalos, and of course Dr. Justin Tuo, who is the GI fellow that kind of championed a lot of the work here, and I'm very fortunate to be able to carry the work forward in the next couple of years. Any questions?
Excellent topic. You're a little brave to present in front of me. So,
Yeah.
Can you go back a little bit? How did that about, just in your description, how you selected the cohort? Can you get into that a little bit more, and why, like what population you were using, since your sample was pretty small?
Yeah, so basically the question was, how do we select our patients, and what are the sort of the criteria that we used? Through our chart review of the hepatology clinic, we just utilized ICD codes of K76, so a MASLD, and that's kind of our primary jumping point. So we didn't really go through whether they had clinically relevant disease at that point. It was just the initial referral ICD codes were for that.
In the hepatology?
Yes.
So I have two clinical questions. One comment that we have been getting denials from our insurers about ordering a elastography. That happened just the last couple of weeks. And, even when the FIB4 is above your threshold of 1.3. So not to mention trying to get a GLP approved. So there's a lot of it. If you really want to work on this, I'm afraid that that's a reality. So my question is the sensitivity of that test where you're missing 15%, is that good enough? And should we be going right to elastography if we could get it covered?
Yeah. So the question is, certainly the FIB4 has a very limited sensitivity, and then should we just go directly to elastography as an assessment? Certainly, I think that would be very reasonable, but at least this, I guess, will be a method of stratifying patients early on. And because of the insurance coverage issues and all the other sort of issues associated with treatment of MASLD, certainly, getting these covered. I wish we could all just go straight to elastography because it's a very easy, simple test, but unfortunately, utilizing as much data as possible to substantiate our, approach to getting these assessments it's probably the only way forward.
I have a follow-up question. So are there other serum biomarkers apart from that give you the FIB4 score that are better or more sensitive?
Yeah, so the ELF score is a little bit more sensitive, and it is a serum marker, so it has few different components. So that certainly is also another way we can assess for it. But again, compared to the FIB-4, getting coverage for it, I imagine is going to be a little bit more difficult. So the FIB-4 is usually a little bit more readily accessible and easy to use. I agree.
Okay, our next presenter is Brendan McNamara, who's going to talk about G-alpha 12 is involved in TGF-beta-induced extracellular matrix production by human lung fibroblasts, and his mentor is Dr. Panettiere. Brendan?
Anyway, so I'm Brendan. I'm a second-year medical resident, and so I'm going to talk about some of the research I've been doing within the Rutgers Institute for Translational Medicine and Science. And so, fair warning, I'm going to talk about skeletal cell biology and more basic science, but I'll try to keep it light. But I'll just get into it. So G-alpha 12 is involved in TGF-beta-induced extracellular matrix production by human lung fibroblasts. Sorry, I messed this up. So what does that even mean? Basically, what I'm talking about today has everything to do with idiopathic pulmonary fibrosis, so IPF. And so idiopathic pulmonary fibrosis, as many of you probably know, is a progressive fibrosing interstitial pneumonia of unknown cause. It's a pretty rare disease, and so in this country, incidence rates are anywhere between 10 to 20 per 100,000 person years, and so fairly rare. And it carries a very poor prognosis, and so median survival with IPF after diagnosis is somewhere around 2 to 5 years. And part of that is because our therapy options for IPF are a little lacking. And so that's what makes it an interesting disease to study. And really what we're trying to do with some of this work is identify future directions for therapies for this. When it comes to the pathophysiology of this disease, we know that fibroblasts in the lung play a central role. And so when you look at lungs with IPF, you see a big activation of fibroblasts, which is associated with abnormal tissue repair and an expansion of extracellular matrix proteins. And so if you look at these pictures of lungs under the microscope, I'm showing normal lung on the left and then fibrosed lung on the right. And what you might immediately notice is a great expansion of the extracellular matrix proteins. And then even down here, you see a group of activated fibroblasts, which really highlights their role in this disease process. And then, of course, at the bottom, I've just included some chest CT images to remind you of the typical imaging pattern of IPF, which is, of course, the UIP pattern where you see this subpleural honeycombing, and that's sort of showing the fibrosis at a more macro level. And I said there'd be cell bio, so I mentioned fibroblasts a second ago. What we know about fibroblast activation in terms of like a cellular level, there's a lot of different pathways that have been implicated in fibroblast activation. And so one of the major drivers of fibroblast activation is TGF-beta signaling. And so TGF-beta is a pleiotropic cytokine. It's important in a lot of different cells, in nearly every mammalian cell. But in the context of lung fibroblasts, we know it's a very powerful driver of fibrosis. And we know it's not just important on the textbook. It seems to have clinical relevance, as we know. Our oldest antifibrotic medicine, pirfenidone, seems to work at least in part by decreasing TGF-beta signaling. So we know it has relevance as a therapeutic target. So TGF-beta signaling drives fibrosis, but there are also some other cellular pathways that have been implicated in fibrosis, though their clinical relevance is unclear. And so I'm just going to introduce the GPCR family of proteins to you again. Hopefully you remember some of this from medical school, but GPCRs are G protein coupled receptors, so it's just a large family of receptors also present on most mammalian cells. And these are the three we'll talk about today, but basically the important thing to know for this talk is GPCRs are protein receptors, and each is associated with a different alpha protein, which denotes its subtype. And depending on what alpha protein you're associated with, you'll have a different intracellular signaling pathway that you activate. And so they tend to do different things in cells. And like I mentioned, they have also been associated with fibrosis in IPF. And so, for example, there was the recent Teton-2 trial that was published in New England Journal just a couple of months ago, which looked at treprostinil in patients with IPF, which is a potent GPCR agonist. And that actually showed that it had some anti-fibrotic properties in those patients. And so there's reason to believe some of these GPCR signaling pathways are implicated in disease. And there's similar evidence in vitro studies for things like G12, and then GQ has been implicated as well. But one thing we don't know really is how these pathways interact, or if they're involved in TGF-beta signaling at all. And that's kind of what our lab has focused on a little bit. And so that brings me to the hypothesis, which is basically that there is some interplay between these GPCR pathways and the TGF-beta pathway that's required for TGF-beta induced fibrosis. So the way we looked into this in the lab is basically our lab gets human lungs donated to us, and we can harvest out the fibroblasts from those lungs and then grow them in culture. And then as a model of fibrosis, I basically take those fibroblasts, I put them on plates, and I stimulate them with TGF-beta. And that, as I mentioned, is a powerful driver of fibrosis, so that will induce fibrosis in these cells. And then to see whether GPCRs matter, I basically do that TGF-beta treatment either in the presence or absence of a G protein knockdown or a G protein inhibitor. And so we examine whether that pathway matters for TGF-beta induced fibrosis. And then I look at expression of fibrosis-related proteins, mostly extracellular matrix proteins like collagen or Pi1. But suffice to say that these are markers for fibrosis in this model. And I look at protein expression by Western blot, which we'll just leave it at that. So anyway, this was the first experiment we did. And so basically I did an experiment in each of those GPCRs. And so the first one here is a knockdown of G-alpha-S, which takes down the GS signaling pathway. And so this slide, I understand, is complicated, but I'll just walk through it. This is basically you're looking at Western blot data. And so each of these graphs are showing expression of collagen and Pi1 here. And then on the right of the screen is a sample Western blot from this series of experiments. And so I'll just walk us through the collagen graph as an example. And I have normal cells on the left, and then the GS knockdown cells on the right of the graph. And basically what you see is when you take normal cells with their GS receptor, you stimulate them with TGF-beta, you see a big increase in proteins like collagen. And so this is expected, this is your fibrosis that's happening. I mentioned that treprostinil signals partly through G-alpha or GS signaling. And so one thing we wanted to look at is whether treprostinil, if we could show that it's GS mediated in this model. And so the next bar here is basically if you treat cells with treprostinil before exposing them to TGF-beta. And what you see is there's a significantly decrease in the increase of like collagen. And so you get less fibrosis with treprostinil acting on these cells. What's interesting is when you do the same experiments in cells that are knocked down for GS, you still see that initial increase in fibrosis after TGF-beta. But when you treat with treprostinil, you get much less of a protective effect and actually no significant difference between these two groups. And so you lose treprostinil's effect. You can see that on the Western blot on the right of the screen. And so just briefly, normal cells are on the left of this as well, knockdowns on the right. And if we just look at, like, for example, collagen bands here, more fluorescence is more protein expression. And so you can see the same pattern where giving TGF, you get a lot more protein expression of collagen. Treprostinil will decrease this, and then in the knockdown model, these bands are fairly similar, and so you lose that inhibitory effect. And so basically from the first experiment, what we were able to show is that G-alpha-S signaling does seem to mediate at least part of treprostinil's inhibitory effects on TGF-beta induced ECM production or collagen production. Next thing we did is I did very similar experiments in GQ and then G12 signaling. And so this is the same sort of thing with GQ. The only difference here is instead of a knockdown model, I did a soluble GQ inhibitor. And so I did a dose response with a GQ inhibitor. And if you look at these graphs again, this is showing like Pi1 and collagen expression, which are extracellular matrix proteins. And so you take control cells, you stimulate TGF-beta, you get a lot of fibrosis. When you do that in a condition with GQ inhibitor, even at the highest dose you did not see any effect on extracellular matrix production in either. And you can see that in both collagen and pi, and then also the similar Western blot over here. And so basically from this, we concluded that G alpha Q inhibition doesn't affect TGF-beta induced extracellular matrix production. And so it seems to not be relevant for at least mediating some of these fibrotic effects. The final one we looked at was G12. And so this is, again, the same sort of experiment setup, but this time I did a G12 knockdown, like for the first one. And again, I'm showing expression of collagen and pi. And basically what you will see is, again, with normal cells, when you stimulate with TGF-beta, you get a big increase in collagen and pi. Interestingly, when you do this in a G12 knockdown cell, you get a significantly less increase in TGF-beta or induced collagen, which I'm showing here. This effect wasn't seen for pi. And if you look at the Western blot here, you can see that in the bands as well, where in normal cells, again on the left here, you see increase in collagen induced by TGF-beta, and that effect goes away in the knockdown. And so from this, we concluded that G12 knockdown reduces TGF-beta induced collagen expression. Yeah, okay, and now we're done. So anyway, the conclusion is basically what I said before, but it seems like G-alpha signaling is important for treprostinil's inhibitory effects, so maybe an anti-fibrotic pathway. GQ is at least not pro-fibrotic, and then G12 seems to actually be a pro-fibrotic pathway. And why does any of this matter? Because seeing how these signaling pathways interact could potentially lead to new therapy targets in the future. And so that's the entire point. And that's it.
I promised you.
I know.
Well, very nice, and it's impressive that you're doing this as a resident. Very impressive. So, do you have other drugs that you're going to test in this model that could be potential therapeutics? And could you choose drugs that are on the market for other reasons that you might have hypotheses could work in this model that you could then possibly test in clinical trials?
Yeah, that would be great. I don't know any like G12 targeting therapies or anything like that exists that would be like that sort of direction. And so currently we don't have plans for that. We're still trying to identify other like proteins important in the pathway and then maybe launch off to therapy options from there. But I wish the answer is yes.
I have a somewhat related question, because in your second two sets of experiments, at least are these, you didn't use the antifibrotic, you didn't test the
Right.
relationship, and why, can you talk about why you made those decisions or why you didn't do that?
So the only one where we looked at like treprostinil was G-alpha S, and that's because G-alpha or treprostinil's a prostacyclin analog. It signals through a couple different receptors, but predominantly GS. And so we just wanted to see if we could test it in the GS pathway, because we initially saw that GS wasn't pro-fibrotic, but we wanted to see if we could at least demonstrate that the anti-fibrotic effects of treprostinil was important. But for GQ and G12, we didn't have like a reason necessarily to examine that.
Hi, back here. I have a question about the treprostinil timing. So you said that you treated the cells first with treprostinil, and
Yes.
then, but have you thought about, like, you didn't rescue the phenotype, or did the phenotype have to have someone on before they develop fibrosis in order for it to be effective based on your model?
Yeah, so we only did pre-treatment. We didn't do like a post-treatment or see if it could rescue or anything like that. Based on like prior studies and what else was done in the lab, most of our models have been like a pre-treatment with this.
I have one question. So these are in vitro studies.
Yes.
They don't often translate to in vivo
Yes.
data. So you have a mouse model or some kind that considering as future studies.
Yeah, so we don't have a mouse model right now, but that would be certainly like a future direction for the lab to take. Yeah.
All right, our final presentation today is from Saloni Jain, who's going to talk to us about clustering patients by social determinants of health, identifies high-risk profiles in acute MI, and her mentor is Navina Yanamala.
Hi, I'm Saloni. Thank you for allowing me to present my research here today. So I'll be talking about clustering patients by social determinants of health to identify high-risk profiles in acute MI. Just disclosures, this work is supported by the NIH and the National Science Foundation. So social determinants of health contribute significantly to disparities in acute MI outcomes, often beyond what our traditional clinical risk factors show, such as diabetes, hypertension, age, etc. Standard risk models tend to overlook the social determinant of health driven heterogeneity in these different patient populations. Topological data analysis, which k-means clustering, allows us to discover these nonlinear hidden phenotypes and patient similarity networks to improve risk stratification for acute MI patients. The purpose of our study was to evaluate how these social determinant of health factors contribute to disparities in outcomes following acute MI. So this was a retrospective single-center cohort study of 729 patients hospitalized within our institution at Robert Wood Johnson. The data sources we used were clinical data from EHR and zip code-linked SDOH metrics from public databases like the CDC that looked at different factors like broadband access, education, income, and more. Our analysis was through topological data analysis to create these patient similarity networks, identifying related subgroups, followed by k-means clustering to identify specific phenotypes. The outcomes we looked at were all-cause mortality. So TDA analysis helped create 3 distinct clusters within our data. The advantages of using this analysis was that it helped detect complex shapes in the data. So TDA, instead of using linear methods to find connections, it actually looks at the data as like a geometric shape and helps identify certain high-risk subgroups or different distinct subgroups that traditional clustering methods don't identify. It works with well with high-dimensional data, especially for something like SDOH variables, given how many there are. And it's robust to noise, especially, again, in the setting of using so many variables. So this, the TDA analysis result here, so each dot basically represents a patient within our data set, and the lines are the ones that are connecting these patients due to similarities and characteristics. And the closer the dots are, they're more related compared to dots that are further separated. So in terms of results, we created 3 clusters, cluster A, B, and C from the results. Cluster A consisted of 110 patients and had subjects with greater social disadvantages and barriers to healthcare access. They tended to have fewer clinical risk factors. However, they had the highest mortality at 16.4%. Cluster B consisted of 300 patients, and these were patients in more favorable environments. However, they were of older age and had the highest burden of comorbidities and had an intermediate mortality at 10.3%. Finally, cluster C consisted of 319 patients, and these were patients with a more balanced SDOH profile, younger age, and had the lowest mortality at 6.6%. Overall mortality was 9.6%. The key SDOH variables that we looked at within each cluster included internet access, post-high school education, median household income, poverty level, Spanish-speaking patients, and public insurance use. So what we saw was in cluster A, they tended to have less internet access compared to clusters B and C. They also tended to have less post-high school education as compared to clusters B and C, and subsequently a lower income. There was a higher level of food stamp use in cluster A compared to clusters B and C, and cluster A had a higher Spanish-speaking population and higher use of public insurance. And these were just some of the variables that we looked at. So when we look at results, so if we look at the Kaplan-Meier survival curve, cluster A had the lowest survival probability. It's the blue line on the Kaplan-Meier curve. And cluster B had an intermediate survival probability, and these were the patients living in the more favorable environment and had a higher comorbidity burden. And cluster C had the highest survival probability. This was the intermediate profile with younger age patients. And then we did a multivariable adjusted hazard ratio of mortality for these patients. Looking at the hazard ratios, clusters B and C tended to have better survival compared to cluster A. However, cluster C was the statistically significant one. So this TDA approach helped identify 3 distinct SCOH phenotypes in acute MI with very different mortality risks, with 16.4% in cluster A, which was the most socially disadvantaged, compared to 6.6% in our intermediate SDOH group. This highlights a paradox, the SDOH paradox. There tended to be a greater mortality in socially disadvantaged patients, even those that carried lower comorbidities and were of younger age. This highlights the fact that social environment and access barriers may be powerful independent drivers of fatal outcomes in acute MI beyond the clinical risk factors that a lot of the risk stratification scores currently look at. And integrating this SDOH clustering into future risk models will help enhance equity-focused care, guide targeted interventions, and facilitate policies to maybe address these disparities. Some limitations of our study was that this was a single center study, so it limits generalizability at this point. Also, we looked at zip code-based databases for SDOH variables. However, individuals within a zip code may have different social circumstances. There was a smaller cohort size for cluster A. It was about 100 compared to the 300 in clusters B and C. And this was a retrospective study design, so we can only get association from this, not causation. In terms of future direction, we hope to validate these findings in multi-center cohorts and looking at a larger sample size within New Jersey and beyond. Develop targeted interventions for high-risk populations, whether that's increasing the number of mobile clinics in underserved populations, helping with transitions of care in patients that are admitted with acute MI on discharge. We also hope to evaluate readmission rates and recurrent cardiovascular events in these patients after discharge. And overall, our next goal is to create an AI model that integrates these clusters that we've created and uses the different SDOH variables to risk stratify patients coming in with concern for acute MI or ACS. I would just like to thank my mentors and the Innovation Center team to make this project possible. Thank you.
Always very curious. Really nice work. I have 2 questions. One is, what was the period of time that you evaluated mortality risk over?
It was, I want to say less than like 5 years for this.
About 5 years. And then, you know, as we're moving forward, I think that topic is very important, right? I think the prevent score, you can stick in the zip code now, right, as sort of a proxy, as you said. But also, there's a mandate that we're collecting social determinants of health data on admissions. Mm-hmm. Is there opportunity in your work to sort of include some of that and be taking a more holistic view as you sort of described?
Yeah, so I think even when we were looking at data now, like there are features in Epic that include these SDOH variables. A lot of times they don't get filled in, but I think given the impact that they have on the outcomes, I think adding that as a feature that is like required for patients that are admitted with these conditions would be very helpful to figuring out their risk and having appropriate follow-up.
Correct me if I'm wrong, but you said age was the older people. Clarify for me about the age issue in terms of.
Oh, in the clusters? Yeah, so I can go back to that slide. So cluster A had patients generally were of younger age and had lower comorbidities. Cluster B had patients that were residing in favorable environments, however, were much older and had higher comorbidities. And Cluster C was balanced. They were younger patients, but they did have not the worst social circumstances, but not the best. I think Cluster A, we are saying, has the lowest comorbidity, but these are patients that may have healthcare access barriers, so they might also have undiagnosed comorbidities given their lack of access. Thank you.
So can I ask a question? So did you control for co-interventions? Do you know LV function? Do you know if they got cath, the extent of their coronary disease? Do you know, did they get post-MI standard treatments, were they all on statins, were their LDLs, beating target and other kinds of standard treatments that we use in patients with acute myocardial infarction?
So we didn't control for all of those variables at this time. Given the main things we controlled were age and sex. We were looking mainly at all these SDOH variables, but certainly that is something that could be important to control for and include in our future work, given that might portray what their mortality risk is aside from the SDOH factors.
But it also might explain why you're seeing differences. Maybe the explanation is just they're not getting, well-established treatments that we know work.
Mm-hmm.
And they may be highly correlated with the issues that you've identified.
Yeah, definitely.
So I have one question. Saloni, that was a great presentation. I just have a couple of questions, honestly. Do you think the clustering actually did better than the conventional risk scores?
We think it did because typically, like the TIMI, GRACE, all these scores tend to not look at these SDOH factors that these patients come in with. I think not only does that, before they're diagnosed, it definitely puts them at higher risk. They might have undiagnosed comorbidities, worse health literacy, but I think also looking at the post-MI phase of for these patients, I think if they have lack of access or not, they don't truly understand their diagnosis, is not explained to them well, they may have poor follow-up and poor medication compliance, leading to these mortality and readmission risks.
So typically at this point we use the GRACE, the TIMI, we obviously also look at the hemoglobin, we look at troponins. Mm-hmm. I'm just curious whether this has outperformed all of that, and it kind of looks as though it might. And the second question is the TDA that you have utilized. I know it actually is a mathematical model that kind of overlaps and takes the geometric assumptions. Mm-hmm. Again, did you look at any other ways of clustering, and why did you pick TDA over the other models?
Yeah, so we didn't use other methods for this data. We picked TDA because of the high number of variables that we have and the way other models tend to do more linear phenotypes and identify linear connections, and sometimes tend to miss the overall underlying shape of underlying shape of the group that helps identify patients that might be more closely related. I think the TDA really, because of, I think, the number of SDOH variables, helps reduce a lot of the noise, and despite the outliers and changes, it's still able to give you a distinct shape that you can then use to cluster.
Okay, thank you.
Thank you.
So one of the issues that obviously is somewhat difficult to examine is what's the contribution of the lack of access versus the contribution of the underlying structural stressors and so forth, right? So within the United States, that's very difficult to examine. However, if you compare this to healthcare systems where access is actually less of an issue, right, with European, particularly Northern European countries, right, are there similar studies that then show that actually the access is not the primary driver, but it's the underlying stress and social deprivation, so to speak?
I'm not completely sure if there's other studies that look at the European population. With this same structure. However, I think a lot of patients that are socially disadvantaged tend to have more of these stressors and have other, priorities where they kind of miss the access to healthcare or don't even have the means or time to get to healthcare and kind of address all these issues. I mean, we see this I'm at Chandler for clinic, and I think we see this a lot there too, where patients just don't have the means to be in the clinic to solve these issues.
Just as a follow-up, I mean, that's an important aspect. Do you know if cluster A had higher rates of hospitalizations?
So-
that may be a clue as to, because they're younger, they don't have other comorbidities. So are they being admitted for the same, rates of MI as the other clusters?
Yeah, so that's actually, we don't have that, but we hope to look at that in the future and how many times they're readmitted and if they have future other cardiac events after this initial one.
Yeah, the future cardiac events again speaks to the access issue. But
Yeah.
I think the initial hospitalization
Oh, if they've
may
had
not
more.
be an issue of access, but more to do with stressors.
Yeah, we didn't look at all of their past hospitalizations. We only focused on the hospitalization for the acute MI for these patient populations. But that's certainly something that we should explore to see if that also portrays an effect.
Great. All right, so the next part of the research day for an hour or so, a little more than that, we have posters out there. Please view the posters and speak to the presenters there, and then there is an award ceremony that happens after the poster viewing. So you'll have to come back for the award ceremony. Let's say 10:15. At 10:15. Okay.
Great job, guys.
Nice job, guys.
In all fairness to you, I think it is one. So it wasn't bad. How are you?
Let's go, man.
Does that mean?
No, of course not. That's why I was like, okay, that's not gonna work.
It's not gonna do.